Good morning. Thank you for joining us. I'll be speaking about challenges in MDS diagnosis. These are my disclosures. Briefly, I'm an employee of Aptos Biosciences. I receive consultancy from Bristol Myers Squibb, Gilead, Takeda, Daiichi Sankyo, AbbVie, and Aztecs, and have received research funding from Bristol Myers Squibb and Takeda. So I'd like to start by saying I wish you were here with me in San Diego. This is where you all should be right now on the eve of ASH, the annual meeting that was supposed to be held in San Diego. And I hope to see you here in the near future, as it's much better when we see each other in person. So what I've been asked to speak about today is how we diagnose MDS and what challenges we might encounter along the way. So we'll start with a very basic introduction. I know we have quite a broad audience here that may include some MDS experts and also people who may have just heard about this disease in the last few weeks or months. So I'll start with talking about when to suspect MDS and how likely a patient is to have it, what the diagnostic criteria for MDS are, both now and how they might evolve in the future. And then I'll talk about some conditions that look like MDS that need to be considered because they might be treated in a very different way. That includes non-clonal mimics of MDS, as well as other clonal disorders that can resemble or even overlap with MDS. And finally, I'll spend most of my time talking about the role of mutation testing to help us discern these challenges and arrive at a correct diagnosis. So we'll start with MDS risk factors. Age is predominantly the greatest risk factor that patients have. And the older individuals are, the more likely they are to have MDS. And you can see that that inflection point occurs somewhere in the mid-60s, with the average age of patients with MDS being somewhere in the 70s. Now, there are some patients who have an increased risk of developing MDS, and these are patients that might have been exposed to genotoxic therapies like radiation or chemotherapy for prior cancers, as well as some environmental exposures. And there are some cases that might be familial or congenital, where a patient has inherited a mutation that predisposes them to have MDS, although it is not necessarily a guarantee that they will develop the disease. Now, how do we go about actually diagnosing the disease, and who do we suspect might have it? We're looking for patients that have low blood counts, and that can be a low hemoglobin, a low neutrophil count, or a low platelet count. And when I say low, it just has to be below the lower limit of normal, and not obviously explained by some other condition. Now, that is not enough to make a diagnosis of MDS, of course. We need to do a bone marrow biopsy. And in the bone marrow, what we're looking for, using a variety of different tests, are signs of the disease that meet our decisive criteria here. And that can include more than 10% dysplastic cells in one or more lineages. It can include 5 to 19% blasts, more than 19% blasts, and the disease gets turned into AML. Or it can include a very specific abnormal karyotype that's typical for MDS. And finally, in the newest revision of the WHO guidelines, a specific mutation can also be evidence of MDS. Now, the techniques that we use to diagnose the disease include flow cytometry. We look at cellularity, we look at dysplasia, we look at blast percentage. We also look at the chromosomes of cytogenetics in fish. And finally, we do DNA sequencing on a regular basis to try to determine which genes are mutated and how this is likely to impact the disease and the diagnosis. Now, I won't do a great service to flow cytometry and cytogenetics, as these are pretty standard parts of the evaluation. While they can be very, very helpful with diagnosis, we're going to focus today more on the DNA sequencing piece. Now, if you get through this point, you've identified a patient likely to have the disease, you've done a bone marrow biopsy. Even if you've met some of these bone marrow decisive criteria, you still have to make sure that there aren't any other conditions that could mimic the disease. These include vitamin deficiencies, viral infections, mineral deficiencies like iron or copper, and exposure to certain toxic substances, including alcohol and certain medications, autoimmune conditions. There's a long list of what we call benign mimics of MDS that need to be excluded because they are reversible in many cases and can be treated more easily than MDS can. So this is the way that I look at MDS in the spectrum of diseases that surround it. So MDS resembles a lot of other myeloid disorders, some other conditions, including autoimmune conditions and lymphoid conditions. And then we have a large collection of these non-clonal processes that I just described that can also mimic MDS. So understanding whether the disease is clonal or non-clonal can be very helpful in trying to ascertain whether or not a person truly has MDS or some other unrelated condition. But it's not quite as straightforward as it looks, and that's one of the challenges that I want to discuss with you today. And we do have some help on the genetic front. That is, the WHO guideline accepts certain chromosomal abnormalities as presumptive evidence of MDS, and they're listed in this table here. And you can see that these are things that we typically find over and over again in patients that tend to be more specific for the disease. So these can be very helpful. And even in the absence of dysplasia or increased blast count, if one of these cytogenetic abnormalities is present, we can say that a person has MDS. The question is, do other genetic features like somatic mutations give us the same degree of confidence when we find them in isolation? So let's change gears now and talk about diagnostic genetics. This is the recommendation from the NCCN about what we should consider when we're suspecting a patient of having MDS. So this would be a patient that has cytopenias and doesn't have another obvious explanation for their disorder. So you can see that much of this list are things that have nothing to do with MDS specifically, like looking at the ferritin, looking at the folate, looking at thyroid stimulating hormone. These are all the MDS mimics that we need to exclude. But you also note that they do now highly recommend genetic testing for somatic mutations. This is something that I've seen evolve over the years, where it used to be not mentioned at all. It's something that one could do in certain highly specific situations. And now it's something that's highly recommended. I suspect that in the near future, it'll be something that we consider more of a standard of care. So how can mutations help us? I want to show you some examples of how mutations can be very helpful and what criteria they need to meet to be so. So the first is if a mutation is very frequent. So take, for example, polycythemia vera. This is a disease that is practically defined by the presence of a JAK2 mutation. If you have a patient you suspect of having polycythemia vera, this mutation is so frequent in this disease that its absence would be very helpful to your making the diagnosis. So this is a situation where a very frequent mutation can be helpful, not only by its presence, but also by its absence. The other condition that can be very helpful is for a mutation that is highly specific for the disease, meaning that it may not be the most frequently mutated gene in that disorder, but when you find it, it tends to point you in that direction. So a good example for this would be CALR with the myeloproliferative neoplasms, that if you're suspecting that a patient has polycythemia vera or chronic myeloleukemia, the absence of a CALR mutation, the presence of a CALR mutation would point you away from those diagnoses and towards essential thrombocythemia or myelofibrosis, where again, it's not the most common mutation, but it tends to be more specific for those diseases. And the question is, are MDS-related mutations fitting into any one of these categories, and can they be helpful in that same way? So let's take a look at our list of chromosomal abnormalities again that are presumptive evidence of MDS. We see that certain chromosomal abnormalities are actually missing from this list, things like del20q or trisomy 8, that are substantially more common than some of these disorders. Find these in a variety of other clonal disorders, and they don't help us discern between them. So we can't use these alone as specific evidence of MDS. Now, there's another chromosomal abnormality missing from this list, that is loss of chromosome Y in men. And the reason that we don't find it here is because there are even normal, hematopoietically speaking, older men who have lost chromosome Y. So this is not necessarily an indicator of disease in these patients and these persons. So we can't necessarily use it as a marker of MDS because it might have been a random background event that has nothing to do with their disease. And again, the question is, how do mutations fit into the spectrum? Are they more like the things in the table or the things that have been excluded from the table? The other challenge with interpreting mutations is that some mutations are difficult to understand the importance of. And often when we get a report back after doing a sequencing study, we get a long list of variants of undetermined significance. And different labs will score these differently. So in an attempt to consolidate the interpretation of these variants, ASH has put together a precision medicine initiative and specifically a somatic working group for hematologic malignancies. And we have come together as a group to try to help annotate certain variants such that we arrive at some degree of unanimity about them, which mutations are important, which mutations can we safely ignore, and so on. And importantly, what are these mutations associated with? Are they associated with a particular disorder? Are they associated with particular disease risk, therapeutic sensitivity, and so on? So our first crack at this is now up on the ASH website, and as time goes on, we'll update it, including more and more variants, and hopefully be an aid to the community, helping them interpret mutations as we go along. So if we look at the mutations that we find in MDS, we see that they look a little different than they do for other disorders like the myeloproliferative neoplasms. Specifically, there is no single gene that's mutated in the majority of cases. In fact, only 10 to 15 genes are mutated in more than 5% of cases. And many of these genes, if not all of them, can be found in other disorders. So we're lacking that frequency criteria and we're lacking that specificity criteria for the majority of mutations that we see. So they tend to be neither specific nor frequent enough to be used as presumptive evidence of the disease. What I take this to mean is that we have to look at these mutations in a clinical context. There has to be other supporting evidence that we put together in order to help arrive at diagnosis, But that doesn't mean that mutations can't be extremely helpful. They certainly can, and I'll show you some examples. The World Health Organization categories for MDS doesn't really rely on genetics very much. It does include a category of del5q, which has been there for quite a long time, and most recently included patients that have SF3B1 mutations, again, in a particular clinical context, that is no blasts, anemia is present, and patients have anywhere from 5 to 15% ring sideroblasts. Now, why aren't more mutations in that table? Well, one of the reasons is that mutations like loss of chromosome Y can occur in MDS where they're actually playing no role in the disease. This is called clonal hematopoiesis of indeterminate potential. And we can see that it has a very strong age dependence that somewhat mimics the age dependence of MDS, but is much, much more frequent. I would say that about 15% of persons in their 70s might have evidence of clonal hematopoiesis like this. Now, this does increase the risk of developing a hematologic malignancy, but that absolute risk is actually very small. What we do find is that persons that have larger clones or more abundant clones tend to have a greater risk. And in fact, in these studies, the persons that went on to develop a blood cancer had varying allele frequencies that were much greater than the average. They were 20 to 30% as opposed to the 8 to 12% that individuals without any evidence of progression had. So what can we take home from this? Is that if a person does have CHIP, it tends to be a single mutation, it tends to be low varying allele frequency, and it tends to be in one of these three genes most often, DNMT3A, TET2, and ASXL1. So if you have a patient that has mutations that fall outside of these characteristics, that may be more suspicious for a myeloid disorder. To give you some concrete evidence of that, we did a study where we examined patients who had evidence of MDS in that they had cytopenias and they might have even had some degree of dysplasia of the bone marrow, but they didn't meet diagnostic criteria. We call these patients having clonal cytopenias of undetermined significance when they also have a somatic mutation in addition to those findings. And when we compare those patients in blue and purple up here to individuals that were definitively diagnosed with MDS, we see some differences in the mutation profile. The one that stands out to me most is SF3B1, where SF3B1 tends to be much more specific for MDS, suggesting that it might be a good gene to use as presumptive evidence of disease, and potentially even more so than we already do in the WHO criteria. The other thing I'll point out is that the varying allele frequency in these persons with clonal cytopenias tends to be much higher than we see in the background of patients with CHIP, and that includes patients who have no dysplasia whatsoever. So the take-home message here is for CCUS that we typically see one, sometimes two mutations, higher varying allele frequencies, some of the same genes mutated, but now we see an increased representation of some of those non-CHIP-like genes, including mutations like TP53 and others, particularly the splicing factors. So if a patient had this profile, it might be more suspicious than that of a person who has a more CHIP-like profile. Now, what about cases that have clonal monocytosis? So where we think a person might have CMML. This is a really interesting study that examined these individuals that would have fallen short of the diagnostic criteria for CMML. But when they studied them genetically, they found that a large proportion of these patients, 57%, had the same types of mutations that we see in CMML, which are shown here, primarily TET2, SRSF2, and ASXL1. But more importantly, their outcomes are very similar to that of patients with frank CMML, suggesting that perhaps our criteria for CMML are not quite broad enough, and we should extend them a little bit further, because even at a functional level, the monocytes that they had the same type of aberrations that we see in patients with CMML. So perhaps patients with less than typical criteria for CMML might be considered CMML in the future. So how do we put this all together? If we have patients who have clonal cytopenias, and we do a bone marrow biopsy, and we don't find definitive evidence of a myeloid malignancy, we can go on to sequence them to see if they carry mutations that put them at increased risk of developing one. And when Luca Malcavati did this in this beautiful study from 3 years ago, he found that about 35% of patients with cytopenias will have clonal cytopenias, and that puts them at increased risk of developing a myeloid malignancy that is much higher than we would expect from comparing the CHIP data, for example. And the risk factors for this tended to be the number of mutations that patients had. More mutations are associated with a greater risk, and the types of mutations that patients had. So RUNX1 mutations, splicing factor mutations, JAK2, and again, multiple mutations was associated with the greatest risk. Single mutations of DNMT3A, TET2, or ASXL1, those CHIP-like genes, was associated with a lower risk, but substantially greater than it would be for CHIP. But importantly, patients who had no mutations whatsoever were at substantially decreased risk of progression. So this is my take-home message from this study, is that if you do a broad genetic panel on a patient suspected of having MDS who doesn't quite meet diagnostic criteria, the absence of mutations is reassuring, and that patient likely should not be considered as having anything that's too MDS-like, whereas patients that have high-risk mutations might be treated as a presumptive MDS patient. This is a summary of the differences between the types of mutations we actually see in MDS, MPN, and AML, and the types of mutations that we see in CHIP, which might be considered background and insufficient to really describe the clonal disorder as being a result of those mutations. So let's change gears now and talk about diagnostic overlap. We've just been through cases that might or might not be MDS and how to help discern them. Now let's talk about cases where there is clearly a disorder and we just need to figure out exactly which one it is. So this can happen because MDS resembles a lot of other disorders, and there can actually be places of frank overlap that are considered separate entities altogether. I think one of them that we can focus on first is the overlap between aplastic anemia and MDS, and specifically hypoplastic MDS that resembles aplastic anemia on a bone marrow biopsy. And this occurs often because dysplasia is difficult to assess when there are few cells to examine. But if we look at the somatic mutation profiling of patients with aplastic anemia, we find that mutations are actually not that uncommon. And mutations in genes that we recognize as being highly associated with myeloid malignancies, like DNMT3A, ASXL1, and even adverse genes like RUNX1 and TP53, while less common, are present in these individuals thought to have an autoimmune disorder and not necessarily a clonal myeloid malignancy. The question is, how do the presence of mutations affect outcomes or affect progression to MDS? And not surprisingly, having these MDS-like mutations or adverse mutations is associated with inferior outcomes and is associated with a greater likelihood of progression. So if I have a patient who has either hypoplastic MDS or aplastic anemia, I'm having a hard time telling them apart, and I do find one of these adverse mutations, it may not really matter what I label them. I'm likely to treat them in the same way and be more concerned about them having a myeloid malignancy. It doesn't mean that you shouldn't treat them with immunosuppressive therapy like you would a typical aplastic anemia patient, because that therapy may even be beneficial in patients with MDS, regardless of whether they have a hypoplastic marrow or not. So let's change gears now and talk about a different overlap syndrome. This is the overlap between MDS and myeloproliferative neoplasms. And this isn't just a group of disorders that share features. This is truly a separate group of entities. This is a collection specified by the WHO as separate disease diagnoses that are neither MDS nor MPN, but truly the overlap between them. And this includes chronic myelomonocytic leukemia, which we discussed briefly already, atypical chronic myeloid leukemia, juvenile myelomonocytic leukemia, and MDS MPN with ring sideroblasts and thrombocytosis, previously called RARST. And you can see that the mutations that define them are very similar to the mutations that we see in MDS. So single genes aren't necessarily going to help us discern this. But what I'll say now is that the pattern of mutation, the profile, how genes coexist, that can be much more informative. So here's an example of the frequency of mutations, DNMT3A being very common in CHIP, much less common in aplastic anemia, and the profile in MDS is quite different. Similarly, the profile in MPN versus MDS is quite different. So if we look at genes not as single entities, but as collections that are part of a profile, we can have a better idea about which disease type we're talking about. So specifically for these overlap syndromes, we find that there are certain patterns of mutation that tend to be more highly specific for certain diseases. Take CMML, for example. TET2 mutations, SRSF2 mutations, and ASXL1 mutations are vastly overrepresented in CMML compared to MDS. And when you find them together, the specificity for CMML is quite high. So this collection of mutations is almost pathognomonic for CMML. For atypical CML, where you may not necessarily have a relative monocytosis, then you might see additional mutations in genes like ZBP1, NRAS, and KRAS in addition to the three above. So that pattern of mutations would be more specific for that disease. And finally, of course, for MDS RST, the combination of SF3B1 mutations and mutations in JAK2 or MIPL or even CALR can be more specific for that disorder. So don't just look at genes in isolation. Look at how they interact with other mutations that might be present. And again, as always, you still have to consider the clinical context. Now, if you find a mutation that is very unusual for that disease that you were considering, then perhaps you do need to go in another direction. So looking for those mutations that are rare or absent in a particular diagnosis can be helpful as well. So another related condition is patients who have MDS and have a relative monocytosis, but the total monocyte count is low. These patients wouldn't meet CMML criteria, but they do have a lot of CMML-like features. For example, the mutational profile of these oligomonocytic MDS are very similar to that of frank CMML, including the TET2, SRSF2, and ASXL1 mutations as being the most common. And when we look at their immunophenotypes on their monocytes, we see that those are also very CMML-like. So this is another instance where perhaps the diagnostic criteria for CMML are a little bit too strict, and we need to expand them further, especially because we know that this division is an arbitrary one, and we have patients that sometimes start on one side of it and move to another, or even go back and forth. So another overlap area that I want to consider is the overlap with acute myeloid leukemia. Just like we have an arbitrary line for determining CMML versus MDS, we have an arbitrary line that separates MDS for secondary AML. And this is a line set at 20% bone marrow blasts. Patients that exceed this number are said to have acute myeloid leukemia, and patients below this number are likely to have MDS. However, this doesn't reflect a particular biological process. It is an arbitrary line that we've set. So how do we discern whether a patient is more AML-like or more MDS-like using their mutational information? Well, one thing we can do is we can look at the mutational spectrum of these two diseases and compare them. And we see that while many of the genes appear on both lists, their relative frequency is quite different. MDS is really defined by mutations in epigenetic regulators and splicing factors like TET2 and SF3B1 as the most common, whereas AML is much more defined by mutations in growth factor pathways like FLT3 or NRAS. DNMT3A is actually overrepresented in AML compared to MDS, and NPM1 is very highly specific for AML, even though you do see it in very rare cases of MDS. Often those cases are headed towards AML. And that's my point, that if you find some of these AML-like mutations in a patient with MDS, you are concerned that that patient is either already very AML-like in their behavior or likely to develop frank AML in the near future. Here's another study that gets at the same question, where they compared mutations that are enriched in secondary AML compared to higher and lower risk MDS, and the same types of genes are popping out as being associated with secondary AML. Those are NPM1, FLT3, PTPN11. MLO-PTD is not on this list, but I think also fits that criteria, and you can see a few others here. So if you do find these mutations in a patient that otherwise would have higher risk MDS, perhaps they are more AML-like, and we need to consider them to be such. So the last overlap area that I want to touch on is not a myeloid malignancy, but is another common mimic of MDS, particularly lower risk MDS with profound cytopenias. And we have a genetic test that can help us in this case too. So if we're thinking about LGL, that STAT3 mutations are actually relatively common in this disorder. So if you do a sequencing panel that includes some of the lymphoid malignancy genes, as many institutions do, you sometimes stumble upon mutations that can help you discern MDS from other mimics that might not necessarily have been detected if you did just a myeloid malignancy gene panel. And these include things like TLGL, hairy cell leukemia, even LPL, and certain mutations that are just simply not found in MDS cases, but are common or even pathognomonic for these other disorders. So to summarize, MDS can be challenging to diagnose, and as some of the findings can be fairly subtle. It can resemble other diseases, and they can be mimicked by a wide variety of benign conditions, making this a challenging endeavor in some cases. Markers of clonality can help us establish the diagnosis when they are interpreted in the appropriate clinical context. So no single gene is diagnostic of MDS, but in the right setting can certainly help us have more confidence in that diagnosis. And now I believe that next generation sequencing, these broad panels of mutation testing, is becoming more standard for the diagnosis and evaluation of MDS. It isn't just for their diagnostic potential. They have a lot of prognostic significance and can help us select therapies as well. And I think in the future, the diagnostic criteria for MDS are likely to change and be more inclusive of some of these genetic abnormalities, much the same way that this has happened for myeloproliferative neoplasms and acute myeloid leukemia. It'll just take a greater understanding of how to interpret these mutations and know how to put them together with the rest of the clinical data that help us arrive at an appropriate diagnosis for our patients. So with that, I'll end, and we'll be happy to take any questions, and we hope to see you in San Diego soon. Thank you.